Fluid and Electrolytes, written and narrated by Dr.Boyd. The topic of fluid and electrolytes is not exciting or even of much interest to most, but the vast majority of hospitalized patients require some form of intravenous fluid therapy. The understanding of the human physiology of fluid and electrolytes is an essential component of their care. The human body is mainly composed of water. 60% of a male's total body weight is water, and 50% of the female body weight is water. So a 70-kilogram male would have 42 liters of water distributed throughout the body, and a 60-kilogram female would have 30 liters. So that's how much water, but where is it? 40% of the total body weight, or 28 liters in a 70-kilogram male, of the water is in the intracellular space, and 20%, or 14 liters, is in the extracellular space, with 15% in the interstitial space and 5% in the plasma. The composition of fluid depends upon which space it occupies. The extracellular space has mainly sodium, chloride, and bicarbonate. The main intracellular ion is potassium. Water is distributed to all spaces and moves between the spaces through semipermeable membranes. So once again, any change in osmolarity of one compartment causes redistribution of water until the osmolarity between compartments is equal. The movement is the result of hydrostatic pressure and colloid osmotic pressure. Because of the permeability of the cell membranes, any change in the osmolarity of one compartment causes a redistribution of water until the osmolarity is the same on both sides of the membrane. Osmolarity is the number of solute particles per liter of solution and is mainly determined by the amount of sodium ions. Serum osmolality is equal to 2 times the sodium plus the glucose divided by its molecular weight plus the BUN divided by its molecular weight. Normal serum osmolarity is 290 to 310 milliosmoles per liter. Sodium is the most important ion in regulating water balance. Other ions can be altered without change in osmolarity, producing only compositional change and not volume changes. The most common fluid disorder in surgical patients is hypovolemia due to extracellular volume deficit. Extracellular volume deficit can be the result of nasogastric tube drainage, vomiting, burns, peritonitis, blood loss, and others. Acute volume deficit. The signs and symptoms are cardiovascular signs of tachycardia, hypotension, and low urine output. For chronic volume deficit, dry mucous membranes and loss of skin turgor are seen. Laboratory findings in volume deficit include an increased BUN and a urine osmolarity that's greater than serum osmolarity. Extracellular volume excess is usually iatrogenic or a result of congestive heart failure, cirrhosis, or renal disease. Symptoms are usually pulmonary and peripheral edema with weight gain. Disorders of concentration also occur. An isotonic solution is one wherein the solute concentration across the semipermeable membrane is the same, and therefore an isotonic gain or loss of a salt solution will cause a change in the extracellular volume with no impact on intracellular fluid volume. However, if hypertonic fluid is given, water will pass from the intracellular space into the extracellular space until osmolarity is equalized. Also, if hypotonic fluid is given, then water will pass from the extracellular space into the intracellular space until osmolarity is equalized. Sodium is the most important ion in regulating water balance. It accounts for 90% of all extracellular fluid cations. It pairs with chloride and bicarbonate to neutralize charge. It's important in nerve and muscle function. The normal concentration of sodium is 136 to 145 milliequivalents per liter. The level of sodium is controlled by aldosterone, renin-angiotensin, antidiuretic hormone, and atrial natriuretic peptide. Decrease in blood flow to the kidneys causes prorenin to convert to renin. Renin converts angiotensinogen to angiotensin 1, which is then converted to angiotensin II by angiotensin converting enzyme in the lungs. Angiotensin II is a potent vasoconstrictor and stimulates secretion of aldosterone from the adrenal cortex. Aldosterone increases renal resorption of sodium in exchange for potassium. An increase in sodium causes an expansion of the extracellular volume. Atrial natriuretic peptide is secreted by the cardiac atrium in response to atrial dilatation caused by excess volume, and it inhibits renin secretion and increases sodium excretion and therefore water loss. The normal serum sodium is 135 to 145 milliequivalents per liter. Normal serum osmolarity is 290 to 310, and the normal urine sodium is 20 milliequivalents per liter or less. Daily requirements for sodium are 80 to 120 milliequivalents per day. A decreased amount of water in the body or an increased amount of sodium in the body leads to an increased blood osmolarity and a decreased circulating blood volume. This stimulates osmoreceptors in the hypothalamus, causing antidiuretic hormone to be released from the posterior pituitary gland. Antidiuretic hormone increases water resorption in the collecting tubules of the nephron, resulting in increased water volume and a decreased sodium concentration. A low sodium, or hyponatremia, means an excess of extracellular water relative to sodium. In most cases, it's the result of sodium dilution or sodium depletion. Dilutional hyponatremia results from excess water and is therefore associated with high extracellular volume. Excessive free water intake or iatrogenic intravenous excess free water administration can cause hyponatremia. Depletional causes of hyponatremia are associated with either a decreased intake or an increased loss of sodium-containing fluids as a result of GI or renal losses due to things such as diuretic or intrinsic renal disease. The syndrome of inappropriate antidiuretic hormone secretion, or SIADH, is defined by hyponatremia and hypoosmolarity resulting from inappropriate continued secretion of the hormone despite normal or increased plasma volume, which results in impaired water excretion and therefore abnormal water retention. The patient exhibits a low sodium with decreased serum osmolarity and increased urine osmolarity. The key to understanding the pathophysiology, signs, symptoms, and treatment of SIADH is the awareness that the hyponatremia results from an excess of water rather than a deficiency of sodium. Common causes include medicines such as type 2 diabetes drugs, antidepressants, heart and blood pressure medicines. Other causes include small cell lung cancer, surgery on the brain or bone, disorders of the brain such as injury, infections, meningitis, or stroke. Treatment options of the hyponatremia of SIADH where moderate symptoms are noted include hypertonic saline, loop diuretics with saline, DDAVP, a vasopressin receptor antagonist, and water restriction. The causes of hypernatremia can be renal or non-renal. The non-renal causes include perspiration, vomiting, and diarrhea. The renal causes would include renal disease, diuretics, and hypothalamic or central diabetes insipidus. Central diabetes insipidus is a defect in antidiuretic hormone as a result of pituitary surgery, closed head injury, or anoxic encephalopathy. The patient exhibits a high serum sodium with increased serum osmolarity and decreased urine osmolarity. There is massive urine output. The treatment is to replace total body water and give desmopressin, a synthetic vasopressin. The daily requirement for potassium is 50 to 100 milliequivalents per day. Hyperkalemia is defined as a serum potassium greater than 5.5 milliequivalents per liter. Peak T waves on the ECG are characteristic. The treatment of hyperkalemia includes polystyrenes like K-exalate, calcium to stabilize the myocardium, and glucose and insulin. Hypokalemia is defined as a potassium of less than 4.0 milliequivalents per liter, and severe hypokalemia is a potassium of less than 2.5, requiring intravenous potassium chloride. The daily requirement of calcium is 1,000 milligrams per day. Hypercalcemia is a serum calcium of greater than 10.5, and severe hypercalcemia is a calcium of 14 or higher. The ECG findings associated with hypercalcemia is a shortened QT interval and peak T waves. Malignancy is the most common cause of hypercalcemia in hospitalized patients. If parathyroid adenoma or hyperplasia is the cause, then surgery is indicated. Volume expansion and calcitonin for mild hypercalcemia and intravenous biphosphonates are indicated in the treatment of severe hypercalcemia. Hypocalcemia is a serum calcium of less than 8.8. ECG shows a prolonged QT interval, and treatment is oral calcium and vitamin D supplementation. The composition of the standard intravenous fluids are shown in the table. D5W is 5% dextrose in water, or 5 grams of dextrose per deciliter, or 50 grams per liter of water. This is obviously hypotonic, but does add enough glucose to help prevent protein breakdown and increases tonicity of half normal and quarter normal saline. Ringer's lactate is isotonic and used mainly in resuscitative therapy. Lactated Ringer's. The lactate is metabolized in the liver to bicarbonate and provides a source of base as well as some calcium. To calculate the amount and type of fluid needed, the first question would be, is this maintenance fluids or resuscitative fluids? Maintenance fluids means the amount and type of fluid to be given to someone who has no deficit, excess, or ongoing losses. The first issue is the amount. One way to answer the question is to calculate the total daily amount and divide by 24 to get the hourly rate. The 150-20 rule is used to calculate the fluid requirement for 24 hours. For the first 10 kilograms of body weight, give 100 milliliters per kilogram or 1,000 milliliters. For the next 10 kilograms of body weight, give 50 milliliters per kilogram or 500 milliliters. Then for each kilogram after that, give 20 milliliters per kilogram. So a 70 kilogram patient would receive 1,000 plus 500 plus 1,000 or 2,500 milliliters per day, or divided by 24, 104 milliliters per hour. An easy way to calculate the hourly rate is by using the 4-2-1 rule. For the first 10 kilograms of body weight, give 4 milliliters per kilogram or 40 milliliters. For the next 10 kilograms of body weight, give 2 milliliters per kilogram or 20 milliliters. For each kilogram after that, give 1 milliliters per kilogram. So for 70 kilograms, that would be 40 plus 20 plus 50 or 110 milliliters per hour. So calculation for the maintenance fluids for a typical 70 kilogram adult male would be as follows. The sodium requirements 2 to 3 milliequivalents per kilogram per day, so a 70 kilogram patient would require 140 to 210 milliequivalents of sodium per day. The potassium requirements 1 milliequivalent per kilogram per day, so that 70 kilogram patient would require 70 milliequivalents of potassium per day. So if the patient needs 3 liters of water per day, and the daily requirement of sodium is 140 to 210 milliequivalents per day, and a liter of normal saline has 154 milliequivalents of sodium, then 3 times 154 would be 462 milliequivalents of sodium, and we would greatly exceed the sodium requirement. However, since half normal saline has 77 milliequivalents of sodium per liter, then 3 liters would give 231 milliequivalents of sodium and meet the sodium requirement. For this 70 kilogram patient, the maintenance fluid order would be 1/2 normal saline at 125 cc's per hour. But we cannot give hypotonic solutions, so we must add dextrose to increase tonicity. Therefore, maintenance fluids for a 150-pound patient would be D5, half normal saline at 125 cc's per hour. But you must meet potassium daily requirements of at least 1 milliequivalent per kilogram. So maintenance fluid orders for a 70-kilogram patient would be D5, half normal saline, plus 20 milliequivalents of potassium chloride per liter at 125 cc's per hour. Resuscitative fluids are intravenous solutions used to restore blood volume and improve circulation in patients experiencing shock or other conditions that lead to massive fluid loss. A fluid bolus is a large dose of intravenous fluid rapidly administered to increase blood volume, cardiac output, and organ perfusion in critical situations. For patients who require resuscitative effort, a good rule of thumb is to give a 500 milliliter bolus of Ringer's lactate over 20 minutes and repeat as needed until urine output increases, the pulse comes down, and blood pressure rises.